Hello and welcome to this point of view walkthrough of how Dr. Staples and I fix a broken elbow. Once the patient is positioned and draped, we use an esch mark to exsanguinate the arm. We then inflate a tourniquet to help minimize blood loss during the operation. An incision is then made with a scalpel directly over the elbow. You can see hematoma and clot escape once the incision is made due to the pressure that has formed in the fracture cavity. We continue our dissection down to bone using an electrocautery knife. This tool can cut tissue while also coagulating blood vessels. The goal of this dissection is to clear away the debris while also exposing bone ends so that we can properly reduce the fracture back into anatomical alignment. Any loose tissue or even bone without adequate connection to a blood supply needs to be debrided and removed to minimize infection risks and poor healing. Once this dissection is complete, we reduce the fracture. Fortunately, in this surgery, a manual reduction with our hands is sufficient. Oftentimes, it requires multiple clamps to bring bone ends together. We insert 2 wires to hold this reduction. The wires span across the fractured zone and provisionally hold this alignment until we can insert the final plate and screws. Prior to placing any more hardware, we take a strong suture called fiber wire and braid it into the tendon of the triceps muscle. The triceps attaches onto the olecranon process of the ulna, right where the fracture is. We can use this suture fastened in the triceps and thread it directly through the plate to help anchor the muscle to the plate and the bone. This helps to provide additional stability to the fractured segment of bone so that the forces of muscle contraction do not cause displacement of this fracture. Once everything is appropriately aligned, we drill directly through pre-engineered holes in the plate and into the bone. Once we reach the far cortex of the bone, we remove the drill and use a depth gauge to measure the length of the hole. The depth gauge tool has a hook on the end that will grab onto the far cortex of bone. The outer sleeve of the gauge can then be lowered to have a reading for length. Using this value, a scrub tech can then give us the appropriately sized screw to be inserted directly into the plate and bone. With the distal end of the fracture stabilized with that screw, we need to provide fixation on the proximal side of the fracture. We drill into the bone and again use the depth gauge to measure the length of the hole. Using a power driver, that screw is then inserted into the bone. Now that both sides of the fracture have a point of fixation, we check an intraoperative x-ray to make sure that we like the alignment and reduction of the fracture. If we are satisfied, we move into the next phase of surgery that we call drill and fill. Because we know the alignment is correct, we can continue the process of drilling, measuring, and inserting screws until the bone has adequate fixation through the plate. Once all hardware is implanted, we can remove all provisional wires. Using the fiber wire suture that we had prepared earlier, we can now tie it down, finalizing the suture connection to the plate. With that suture tied and the ends cut, we run the elbow through gentle ranges of motion to ensure a smooth movement without any clicking or catching in the joint. With the open reduction and internal fixation completed, we move on to the closure of the wound. Dr. Staples places deep sutures to approximate this layer of tissue. This stitch is a strong dissolvable material. Given the location on the body, a proper closure is crucial. If you feel the tip of your elbow, there is not much more than skin and bone. After Dr. Staples secures this deep layer, a call is made to the bullpen for the true closer. Using a thin, yet strong, dissolvable suture, I approximate the most superficial layers of tissue. Starting at the proximal end of the incision, I sequentially work my way to the end of the wound. There are various forms of suture material that can be used here. Some sutures you can run along the subcutaneous tissue without needing to cut. Some sutures, like the one seen here, needs to be cut separately after each knot is tied. Depending on the patient and the area of the body, will determine which suture ultimately is used. Due to the metal we've now implanted, we need to make sure that this incision heals nicely to avoid infection, because the metal is basically at the surface of the skin. With this layer of suturing complete, we use a skin stapler to complete the closure. These staples will be left in for 2 to 3 weeks and then removed in our clinic. Given this type of fracture, we place patients on weight-bearing restrictions for 6 to 8 weeks. Patients will also be under strict range of motion limitations as the fracture begins to heal. With time and physical therapy, patients can expect a very functional recovery. Thank you for joining on this orthopedic point of view walkthrough. Make sure to subscribe, and we'll see you next time in the OR.